morphogens. It can therefore be seen how some patients require products from all three categories in order to obtain the optimum response from their bodies. So to recap, we have three categories of glandulars: whole glandulars, protomorphogens, which is the DNA extract, and aqueous cellular extracts. Okay, now, who approached me during one of the breaks and asked me to fix her, and I said she'd have to wait till session 2 with the chronic hypermobile SI joint? Come on up. Okay, get rid of your gum. Man the pump. One of the things we're going to discuss in session 2 is the adrenal glands in great depth. And the adrenal glands are very, very important. One of the things we typically see, especially in professional students and in professionals, go ahead and lay on your back, is either a hypo or hyperfunctioning of the adrenal glands. Now, this can create breakdown products known as adrenoleukin and adrenochrome, which have a tendency to attack specific ligaments in the body, either the sacroiliac ligaments and or the upper cervical ligaments. If we test a muscle related to the adrenals, bend here, drop your knee. I'm going to pull down, you pull up. Are you on any medication at this time? Pull hard. And that's pretty good. Drop it down, pull up. And that's pretty good. In the clear. The sartorius is one of 5 adrenal-related muscles. Now, lift your head up, chin to your chest, push up. And just relax. I'm just going to, and push up hard. No problem there. Now, TL both SI joints with your hand. Got it? And pull up. I'll try again. Maybe one more time. That's what we call the emotional low back syndrome. And her SI joints are inflamed, and you will never get well until we get them adrenals cooking. Okay? Now, throw me some whole adrenal. That's what's known as a handoff. Put that on top of the tongue and move it around so you can taste it. So don't put your hands back where you are. Got it? Taste it. And hold up. That's the truth. Her legs are strong. They are strong. So, that is a whole adrenal concentrate, which I would give for her 1 an hour until we see you next time. You have hypertension. Okay. If she did that, probably would be contraindicated. We're going to go through each of those things. Okay? No sugar. Bread, pasta, rice, potatoes, pie, cakes, cookies, okay? Whole adrenal, 1 an hour. Okay? So any questions on the glandulars? I just want to get through nutrition, and we're going to call it a day, and we'll start in the morning. I just want to finish up nutrition. This is an introduction to nutrition. 1 per hour, except when she's sleeping.
You would have seen her in your office.
Probably in 2 to 3 weeks. I only see, most of my patients are either once a month or twice a month. I can only think of, 2 patients right now that are once a week. One is my adopted father in Vegas. The other one is my cousin in Vegas. Figures, right? But with those 2 exceptions, right now, currently in my office, everyone is either once a month or twice a month. That's true. Right, Dorothy? Now, turn off the lights for a second for the projector. I just want to finish this up. If anyone asks you about oral nutrient testing, there's a pathway that's written for you in your handouts, and in your workbook. But realize that AK testing is supplemental to the history the particular health concerns and problems, physical, lab, if they're on any medications, and then some of the other special tests. Now, we can also test, besides testing good things for the patient, we can also test things that the patient may be sensitive to. For example, light sugar, or wheat, dairy, corn, and soy. Now, write these down. We're going to finish up. Just give me a little bit of a leeway, like just a couple of minutes. Just bear with. I just want to finish up this section. Wheat, a good muscle to use is pec major sternal. Corn, supraspinatus. Dairy, psoas. Rob, you don't have any food sensitivities? Wheat, pec major sternal. Dairy is psoas. Corn is supraspinatus. Soy is possibly infraspinatus. That's a big possible. John, do you have any? Okay, come on up. Just for demonstration. So, one of the things you'll find is I would highly, highly, highly encourage you to check all of your patients for wheat, dairy, and corn in your bathroom. We're almost done. We're just going to finish on nutrition. So let's push. We'll take a pec major sternal. I'm just going to demonstrate one. And that's pretty good. That was pretty strong in the clear. Push. That's pretty good. Just relax, John. That's pretty good, isn't it? Pretty good. Not for long. John, TL the atlas on the left with your thumb. Take your watch off. I know that's a battery. I'll put it up here for you. TL the atlas on the left with your thumb. Okay. TL the atlas on the right with your thumb. Pretty good? Sean, I want you to eat a pizza every day. Because I'm just starting my practice and I need your atlas to go out all the time. I just have a little bit of wheat. Chew that up, put that on the tongue. It's actually wheat kernels. Did I get you? That's actually wheat kernels. Usually I do that with a pill. I get the pill roll down the throat pretty good. Push, push, push. Maybe one more time. Push. But it won't weaken all the muscles. Push. That's why I told you certain muscles with certain foods. Now, TL the atlas on the right with your thumb. Were you ready? I don't believe you. Push. It just blew out his atlas. Watch. Instant dural torque. So I'd like to get a pizza a day. We'll have a standing appointment for you. Okay, that's a joke, of course. But please check your patients. Check your patients for wheat, dairy, corn. Wheat, pec major sternal, dairy, psoas, corn, supraspinatus. Please. Yeah. Is it the wheat or is it the gluten? I don't really care. I don't really care. It doesn't really matter. No, not necessarily. The question is, can these people eat barley and rye? I usually tell them no.
Is there a muscle for sugar or for chocolate?
Is there a muscle for sugar or chocolate? Some people Okay, hold your horses, give me just a couple of seconds. Hold on, I got a big finish. What time do we start tomorrow, Dorothy? 9. Hear you. 9 is it 9? Okay, we are in San Jose, all right, Santa Clara. What was the question? Oh yeah, sugar. Some people that are very sensitive to sugar will cause a universal muscle weakening. Some people won't, but usually a good indicator will be any adrenal or pancreas-related muscle, like the sartorius that we saw up here, a latissimus dorsi for the pancreas, that type of thing. Okay? Difference in sprouted grains. You can paint a leopard with stripes, but it's still a leopard. Put the lights on, and we're just going to finish up. And so we can also test adverse substances: sugar, wheat, dairy, corn, soy. Is that amazing? So we diagnose the need, we supply the need, and we observe the results. There is cause for everything that happens in the body. Now, we're going to see you at 9. Don't wait, wait. Are we scheduled until 6:15? Yeah. I'm only like 7 minutes, right? Then it'll be worth it. Standing for what you believe in, regardless of the odds against you, and the pressure that tears at your resistance, means courage. Keeping a smile on your face when inside you feel like dying for the sake of supporting others means strength. Stopping at nothing and doing what's in your heart you know is right means determination. Doing more than is expected to make another's life a little more bearable without uttering a single complaint means compassion. Helping a friend in need, no matter the time or effort, to the best of your ability means loyalty. Giving more than you have and expecting nothing but nothing in return means selflessness. Holding your head high and being the best you know you can be when life seems to fall apart at your feet, facing each difficulty with the confidence that time will bring you better tomorrows, and never giving up means confidence. See you in the morning, guys.
I just zoomed in on your whole head right there. Yes. Show me that meat head. I'll lift it up. Right.
And what we learned yesterday is that we walk on average, according to ISOGI, about 6,000 steps a day. And when we walk, if we put our right foot forward, which upper trap turns off? The IPSI, which SDM? The contra. And if not, where do you work? Where do you work? But where do you look first? Look to where the dur attaches here, and then here. Use your tool of therapy localization to track it down. That will identify the area of lesion structurally. Now, we also have a lower half the gait when we bring the ilium forward on the forward leg side. The sacrum on that side goes backward due to inhibition of the ipsi piriformis, and the TP of L5 goes forward, limited in motion by the iliolumbar ligament. And it has this type of motion as we walk. So if we test the piriformis, it should be strong, but then when you place them in a gait position, it should go weak. That's just normal physiology based on the work of the Swiss chiropractor Fred Illy, who did the research at Nashville during the 50s. People also bend, and when you bend, there has to be rotation in the spine. Without rotation, you can't bend functionally. And on 30 degrees flexion or 15 degrees extension, the left upper trap, the left lat, the right SDM, and the right piriformis should shut off. That's just normal physiology. And you can use just one muscle. I usually use the left upper trap. Whether they're right or left-handed has no bearing. And if it doesn't work, use your tool of therapy localization. Check here, and fix what you find. Now, people also chew. And if you realize what two muscles are the largest ones that attach up into the cranium, upper trapezius, SCM. And those muscles have a dual nerve supply, cranial and spinal, and they turn on and turn off and gait in a cross-crawl fashion. We are quadrupeds who have learned to be bipedal. Muscles move bones, bones don't move muscles. There's about 650 muscles in the body, 210 bones. The eyes are some of the most powerful reflexes, the visual writing reflexes. The eyes should track together, and if a patient weakens a strong indicator muscle with eyes up to the right, that's the occiput on the right, and if it's eyes up to the left, left occiput down to the right sacrum down to the left sacrum, straight right, C2, straight left, C2, straight down, base posterior, straight up, apex posterior and or bilateral inferior occiput. We learned to test for an occiput lateral, and that's to take a strong indicator muscle, have the patient stick their tongue straight out. If they weaken, that's a hyaloid problem, but if they don't, and it's out into the right, that's right occiput, out into the left occiput. We learned about the primary atlas technique, and when you therapy localize the atlas, you should use the patient's thumb. There's no C1 sensory nerve root, so we use the thumb to TL the atlas, and on atlas laterality we'll have weak wrist flexors. Very good. So that's an excellent way to start. You're going to fix more people if you get that stuff right. You'll be fixing everyone else's failures. I have a failure practice, which means I see everyone else's failures in general. We have people that fly in pretty much every day from all over the country, actually even outside the country sometimes. And Good Heart could have a 1-900 number of 10,000 plus conditions, and you have one answer. Fix what you find. Don't think you can fix the label, and by fixing the label you can fix the person. Fix the person who's been labeled. Now, what I'd like to do today is let's get through these next section of muscles, and what I'll do is I'll lecture on each muscle. I'm going to follow pretty much right in your workbook. I'll be adding little comments. I want to get through all the muscles lecture-wise, then we'll workshop it. So we're going to get through the muscles, and if we have to, we'll just break it up into 2 workshops if we have to. So we'll have one group take a wee break, we'll workshop the one, and then when they come back, that group can take a wee break, and then we'll do the other workshop. So if we have to do it, that's only for session 1, and I apologize, we did not expect such a wonderful response, and so we will be prepared for that next time. If you could please let Dorothy know, if you've only paid for session 1, please let her know so that we can plan for that accordingly. So if somebody could put the light on the projector, and we're going to start at the pectoralis major sternal. Can you all see that okay? Is it lighter in here today for some reason, or maybe, is it better that way? Okay. Can you see the light okay? All right. Maybe because we have a morning sun or something, but so turn your workbook to the pectoralis major sternal if you would. So I'm going to lecture on all of the muscles first, Then we're going to take the books off and we'll split the room up into two groups. The first group will take a wee break and we'll workshop, or the one group will take a wee break, we'll workshop it, and we'll switch. We'll do it that way. So turn your workbooks to the pectoralis major sternum. I would give you the page number, but that really wouldn't help you to find it. Okay? Use your red pen for the muscles, blue pen for the tendons. Now, let's say you have a sprain strain come into your office. You're going to have a trilogy of what? 3 muscles. One will be weak. And what will that usually respond to with trauma? Excellent. Origin insertion. And you simply use your tool of therapy localization, check at the origin and the insertion. And how would you fix it? Just a hard rubbing pressure of trying to push the tendon back on the periosteum. It's a microavulsion. And the least painful way to do that is to put the patient in the strain, counter-strain position. What's the nutrition? Phosphatase enzyme found in the standard process product of BIOS. Now, if it's not origin insertion, we then go to the Golgi tendon organ, and they're located at the musculotendinous junction. And so we go here and here for the bicep, and if that turned the muscle back on, how do we fix it? Go at that musculotendinous junction and push towards the belly. Okay? And if it's not the Golgi tendon organ, it could be the spindle cell, excellent, and they're located throughout the muscle, but are concentrated in the middle 1/3 of the belly of the muscle. So we would use our tool of therapy localization. If that turned the muscle on, how would we fix it? Go into the belly and, excellent, pull apart. Just the opposite of the GTO. And what's the nutrition for those two? Same as for origin insertion, phosphatase enzyme found in the bio product. Now, the synergist to the weak muscle will have a trigger point type of pain known as a strain, counter-strain, and to diagnose it, that's a strong muscle that weakens after a 3-second maximum contraction. And how do we fix it? Fold and hold, passive on the patient's part, active on the doctor's part. Usually it's flexion if it's on the front, extension on the back. And when we find the position that decreases the pain from an 8, 9, or a 10 to a 0, 1, or a 2, we then have the patient take a breath, again if it's on the front and out if it's on the back. And that just decreases the amount of time that you have to fold and hold. And then what's the really important part of it? Slowly we return it back to its original position so as not to recreate the strain, counter-strain. Now the antagonist to the weak muscle, that will be the tightened or short muscle, and that will respond to fascial flush to diagnose it. That's a strong muscle in the clear that weakens after a gentle stretch. And how do we fix it? Iron out the muscle along the muscle fibers towards the heart. Nutrition is B12, and for the strain counter-strain is folic acid, primarily and/or glycine. Excellent, very good. Any questions about that trilogy for sprain strains? That's the more common injury. That's the 9 out of 10 that you'll see. Okay, excellent, very good. So let's start with the muscles now. Pectoralis major sternum comes off the sternum, and the fibers twist into the intertubercular groove. It is a flexor and ABD adductor. It's related to the liver, and it's on the liver meridian. The nutrition is vitamin A, and there are 14 different isomers of A, bile salts, and liver substance. You may want to also write in there products like AF beta food from standard process, beta col, which has the anti-stiffness factor Dr. Woolsey discovered that from the University of Washington. It's the factor in raw cream, beta called Livoplex. Selenium, now if a patient needs bile salt, that's the cholecol product from Standard Process, and the way you give bile salt is you cycle it. 1 3 times a day, 2 3 times a day, 3 3 times a day, 2 3 times a day, 1 3 times a day. So you cycle it up and you cycle it down so that they don't get used to it and their body stops making it. So you want to cycle the bile salts. That's the cholecol product, and that's the drip, drip, drip kind of sinus. There's only 2 kinds of sinus, drip, 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 and stuffy can't blow it out. The stuffy can't blow it out is an E4 iodine, which is a metallic taste in the mouth, and the drip, drip, drip kind of sinus is bile salts. That's a bitter taste in the mouth. Does it make a difference if they have gallbladder surgery? Yes, they definitely tend to have biliary problems. So they took out the light bulb, but they didn't take out the wires. So they still have a gallbladder meridian, a gallbladder circuit. Very often, if they take out the gallbladder because of gallstones, then what happens? They start to make kidney stones, because then the body can't make it in the gallbladder anymore, and there's no other place to make it, so it starts to make it in the kidney. Okay, the reflexes, again, the neurolymphatics are where, in general, on the body, over the organ. So it's the 5th intercostal space on the right, T5 lamina on the right, and the neurovasculars are above the emotionals, out slightly where the hairline used to be. Right about there, for me, or maybe a little lower even. My face keeps growing every year. This is how you test the pec major sternal. It's full extension, full internal rotation, and then the vector is sort of opposite the acis out. So, John, you want to, since you're close, move that other chair away because you'll be coming up here all the time. Good morning. Laying your back here. The new diplomate. I remember when I got mine in 1990. I was actually more proud of that than my DC degree. That's okay. That's right. Really worked for it. Elbow straight. I'm going to push opposite the acis. John, you push in first. Push, push. And that's a good one. And let it go. And go out in that direction. Okay. Probably the hardest diplomate to get. Now, the pec major clavicular is the next one. It comes off the medial 1/3 to 1/2 of the clavicle, and its fibers also twist into the intertubercular groove. It's a flexor and internal rotator. The pec major clavicular, which we'll call PMC often, is related to the stomach and the stomach meridian. Nutrition would be beta-ene hydrochloride, and even though we have our patients chew all their supplements, we don't have them chew acid-based products. Why? Because it takes the enamel off the teeth. So make sure if you're telling all your patients to chew their supplements, which you should, don't have them chew beta-ene hydrochloride, Zypan, RNA, any Calamo, any acid-based product, don't have them chew. Stomach tissue with vitamin B12. Why stomach tissue? Can B12 work without intrinsic factors? No. Can B12 work without cobalt? No. Now, what's necessary for the stomach to make hydrochloric acid? What cofactor?
Zinc.
Zinc. Zinc. It's a zinc-dependent system, and so many times also zinc can be related to stomach. the sixth intercostal space on the left, T6 lamina on the left, and the emotional neurovasculars. It should be all in your workbook. The test is full internal rotation, pushing out and slightly down, stabilizing the opposite shoulder. Laying back here. So you can do that from that end of the table. I prefer from the head of the table. Elbow straight. And I'm going to push down and out and let it go. Kind of in that direction, so following the muscle fibers. You can also test it like we learned yesterday together at the same time. You can also do that as sort of an indicator test. A bilateral pec major clavicular weakness, when tested together, is an indication that the patient has a temporal bulge, cranial bulge, with a corresponding hypochlorhydria. The old name for that is banana head. The next group of muscles, it's actually a group this time, are the quadriceps. Most people don't test this one properly at all. The quadriceps are made up of the vastus medialis, the vastus lateralis, the vastus intermedius, which is deep to the rectus femoris. So there are four that attach to the patella and then go into the tibiotubercle on the tibia. They come off the thigh except for the rectus femoris, which comes off the acis. Vastus medialis coming off the proximal femur, medial side. The vastus lateralis from the lateral side. The vastus lateralis again. I'm sorry, vastus intermedius. Now, weak quadriceps, many times you'll see a genu recurvatum or hyperextension of the knee. Also, a weak rectus femoris many times will allow a PI ilium on the ipsi side. The quadriceps are one of the small intestine related muscles. It's on the small intestine meridian. It's also one of your vitamin D muscles. What's the other vitamin D muscle for those that have taken the course before? TFL. So the TFL and quadriceps are your vitamin D, but the quadriceps are also a vitamin D muscle. Some other products you may want to consider: CoQ10, glutamine. Glutamine is the fuel for the small intestine from Thorne. Cholecol-2, not cholecol, which is the bile salt product related to the liver, but cholecol-2. Cholecol-2 has bentonite. Bentonite acts like little scrub brushes to scrub out the villus and microvillus spaces when they get clogged up and leads to an absorption problem. So cholecol-2. Another product from standard, ochrapepsin E3. Ochrapepsin E3. Ochra is like WD-40 for the intestines. Ochrapepsin E3, and that's a way of dissolving out the villus and microvillus spaces. So you have two ways: you can scrub it out or dissolve it out. The quadriceps lymphatics are at the costal cartilage and T8 through T12 lamina. The neurovasculars at the posterior parietal eminence. That's actually a pretty good slide of testing a weight-bearing quadriceps. The patient would be on the table. John, come on up, and usually this jacket doesn't last too long. Want to lean back? test the quadriceps supine, one of the important things you want to do is be on the side that you're testing, and so that you can grab the opposite knee. Now his knee that you're going to test can rest on your arm, that's the support. You bring the leg up, not completely extended because you'll never get it, but just slightly bent. Now, don't do this. Pull up here. Don't test it like that. Get your body right next to it with the elbow above the foot. Push and test it that way. That's actually a good one. Let go. Pushing in a geometric fashion down. Push. But don't do it like this. Do it like this. Don't do it like this. Do it like this. Now I know during the workshop, somebody's going to do it like that. That's okay. Wait. Okay. Actually, come on. Just relax here. We've got to have a real change. And if you can grab that other box for me, that would be great. Okay, who put the little pelvis in my carousel? You. Thanks a lot. The rectus femoris comes off the acis and aiis into the patella. It's a flexor. Weakness will allow the PI ilium oftentimes. Ipsy side. And that's a real good slide. But you should be on the same side as you're testing. So instead of testing across the body, just walk around the table. Bring this one up. Push up. Go ahead. Push, push. Push, push. That's actually a weak one. Push, push. Push, 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 push. That's a weak one. Whereas this other part of his quads were strong. Okay. All the same reflexes for the rectus femoris as the quads. All the same. All the same nutrition. The next muscle is the psoas. What if I want to isolate the vastus medialis? I'm going to show you that later. Let's just get the basics down first. It's kind of like when you teach, you have a bell curve of the class, and you got plus or minus 1 standard deviation, plus or minus 2, plus or minus 3. You've got to try to teach for the plus or minus 1, and you've got people on the left-hand side of the curve and people on the right-hand side of the curve. So you don't want to lose these, and you don't want to bore these. So you have to kind of take it step by step, and that's what I'm attempting to do. The psoas muscle comes off the lumbar vertebrae and the discs, It goes into the lesser trochanter. It's the major what? Hip flexor, and also an external rotator. It also provides support to the anterior lumbar spine, as well as the discs. And one of the ways Goodhart started developing this muscle-organ relationship is that he noticed that patients with kidney stones, they would have a convex curve away from the side of the kidney, and that psoas would always test weak on the concave side. So that was one of the things early on that he started to observe. He has excellent powers of observation. Bilateral loss will allow loss of the lumbar curve. It's related to the kidney. It's on the kidney meridian. Is that a little more clear? Vitamins A, E, and kidney tissue. Remember, there are many kinds and sources of vitamin A. Beef kidney fat source can lower cholesterol, but not the fish oil source. Fish oil source is good for night blindness, but so there are different applications for the different fractions. Well, what's the most important nutrient for the kidney? Water. Water is the most important nutrient for the kidneys. And many times you can take a weak psoas and just have the patient hold water in their mouth, and it'll strengthen up phenomenally. Dehydration is one of the biggest things we've got, one of the biggest problems we have. Dehydration. The neurolymphatics are 1 inch up and 1 inch out from the umbilicus. One up, one out. The lamina of L2 posteriorly, over the TPs. And the neurovascular is 1 inch to 1.5 inches out from the EOP. That's all in your workbook. Now, when you test the psoas, I prefer not to stabilize the opposite acis because it's sensitive, and also many people, when they test, they'll actually put pressure over here, which does what? Challenges the SI joint on that side. So taking contact just inferior to the ASIS. John, you want to come on up? So we just take the leg now, full external rotation, full knee extension, bring it up about 30 and out about 30, stabilize just below the ASIS. John, you push up. Push up, John. Push up. That's the weak one. Now watch. Dorsiflex your foot. Turn it out and up. Push up, John. Don't dorsiflex your foot, John. Push up. Little nuances that if you know what you're doing make a big difference. Don't allow them to dorsiflex the foot. That stabilizes the talus, turns the weak psoas back on. You get a false negative. So, foot is in neutral position, full external rotation, up 30, out 30, stabilize below the ASIS, push, 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 push. Okay? That's a weak one. Just push straight down. Don't go away. The next muscle is the iliacus. It has all the same reflexes as the psoas. It comes off the iliac crest, anteriorly goes into the lesser trochanter. It too is a hip flexor and lateral rotator. It also helps to stabilize the anterior portion of the sacroiliac joint on that side. And just put a big X through the muscle test in your workbook for that one. Big X, because that's wrong. The best test for the iliacus is just straight up. So bring it to the midline, still come up 30 degrees. We're just not doing what with the psoas? We're not bringing it out 30. So we're just bringing it straight up in line with the muscle. Push up. That one's also weak. So he also has a weak iliacus on that side. So the difference is, here's the iliacus, here's the psoas. What they're showing in the book is they bring the iliacus way out here. I don't like that. I prefer Beardall's test. Okay, now, the iliacus many times is related to blood pressure problems. Some products that you may want to write down is Alboplex from Standard Process for kidney infections. That is an excellent product for kidney infection. Alboplex. Arginex, which is a kidney detoxifier, which has the enzyme arginase, which is part of the urea cycle. Arginex is an excellent kidney detoxifier. Actually, there's Arginex product in the Alboplex for kidney infections. Now, when you measure the urine on the adult, what should the pH be? 6.4. So if they have a bladder infection or kidney and the pH is 7.5, what would you think to do? Besides the neurolymphatic, the neurovascular, Alboplex or Arginex, what else would you do? Right, raw, unfiltered cranberry juice, first thing in the morning and last thing at night before sleep only. And that will re-acidify the urine. What will increase the alkalinity of the urine? Potatoes, milk, that type of thing. Okay, so once in a while it will be too acid, but most of the time it'll be too alkaline. So you just measure the pH of the urine, should be what? 6.4 in general. And then usually in a bladder infection or kidney infection, it'll be too alkaline, usually, but measure it. Cataplex A can be useful in kidney stones. Also, phosphate liquid from standard process can help dissolve kidney stones. Phosphate liquid. All the same relationships for the iliacus as for the psoas. That's how not to potentially get that. Yep.
If I heard correctly, you said L2 for L2 for the picture, like on TB12.
Well, that looks like T12. Oh, I'm sorry. You're right, T12, lamina on the back for both the psoas and the iliacus. Your workbook is correct. Sorry about that. It's still one up and one out from the umbilicus, but you're right, it's the lamina of T12. Thanks, Alan. Okay, the next one is the gluteus medius, and also for this course we test the gluteus minimus with the gluteus medius sort of as a group test. The gluteus medius comes off the outside of the iliac crest and comes over to the greater trochanter. It's the major hip ABD abductor. Gluteus minimus comes off the iliac bone inferior to the gluteus medius and over to the greater trochanter. For this class, we're testing them together. When it's weak on one side, here's gluteus medius, gluteus minimus. There's a particular postural pattern which you'll see, and that's high, high, high. High hip, high shoulder, high occiput on one side. High, high, high. When you see that, you know that's a weak gluteus medius on the ipsy side. The gluteus medius, as are the other pelvic muscles, related to the reproductive organs. Isn't that interesting? So not only the gluteus medius, gluteus minimus, but glute max, piriformis, all your pelvic muscles are reproductive related. And they're all vitamin E related, except for one. So we have vitamin E, male or female, glandular tissue. They're on the circulation sex meridian. Other synonyms, if you're reading textbooks on acupuncture, are pericardium and heart constrictor. Those are all synonyms for circulation sex. Pericardium and heart constrictor. Yeah. Yeah, so if you have a high iliac crest, high shoulder, high occiput, the weak gluteus medius is here. Rub them K27. Okay, now, there are different types of vitamin E. I'm going to give you some general guidelines. These are good guidelines. And in general. The Cataplex E product from Standard Process that Alan strengthened to yesterday, when he had the bilateral glute max, that's very good for musculoskeletal conditions. Cataplex E, the dry tablet from Standard Process. These are general guidelines. Cataplex E2 from Standard Process is like our nitroglycerin product. So that would be for what type of patient? Right, androgenous patient. Okay, that works better than nitroglycerin, actually. That thins the blood. Cataplex E2, that's for your angina patient. Your E3 that's like intestinal. So like oprapepsin E3 product. So we have one for musculoskeletal, one is for angina or like a thrombophlebitis, that's your blood thinner, and then the E3 is intestinal. Now, for reproductive problems, you want an oil-based E, like wheat germ oil. So reproductive, you want to go with the oil-based E, like wheat germ oil pearls from Standard Process. So that's a good general guideline for your different E products. Okay. Now, for the gluteus medius, it's the upper pubes on the front, TP of L5 on the back, and the neurovascular is the same as the quadriceps, the posterior parietal eminence. This is a great slide. This is the best test for gluteus medius, which is side posture. Very often you'll see people do a supine glute medius test. That's a very poor second test. John, lay on your side, facing them if you would. Bend your knees here. And what we do is have John stabilize here, and no therapy localization, so hand away from the body. The pelvis needs to be perpendicular to the table. What you'll see if they recruit, what they'll tend to do is they'll want to rotate the pelvis back to recruit the tensor fascia lata. So you want that pelvis kept perpendicular to the table. The bottom one is bent to help stabilize. We bring the top one up straight. John, you lift it up. Keep the foot in neutral. What they'll tend to do too is they'll externally rotate back to recruit. So keep that foot in neutral. Keep the pelvis straight. Stabilize at the hip here. And John, you push up, I push down. John, you push up. That's a weak one. Now, cheek light hack. False negative. Put it back proper push. Weak as can be. That's a little nuance. Now, lay on your back. This is the supine test. The foot should be straight. Bring it out. Don't bring it up. So keep it down. Push out. See how you miss it? Lay on your side. This is the way to do the glute medius. Side posture. Try not to kick the doctor. Stabilize here, not touching here. Bring this one up. Push, push, push. That's the weak one. Okay, that's the best test for glute medius. Ooh, yes. Bad test. Okay, next muscle, tensor fascia lata. I know you're not going to remember all the different ways how to muscle test. That's what the workshop is for. So just get it in your notes now. I want to just get through the slides. We're going to break up in two groups, and we're going to workshop it. That's, you know, educators have rated learning on a relative scale from 0 to 1,000. And by listening, it's about a 10. By watching, it's about 100. And by doing, it's about 1,000. So you learn by doing it. That's why they call it practice. How do you learn to play violin or piano? By watching, listening, a little bit. But you learn it by do it. How do you learn how to adjust? You got to do it. Same with AK. It's not only a skill here, but it's a skill here. You have to learn it. It's a kinesthetic skill. The tensor fasciolata comes off the acis. It's a little tiny dude. It's a little tiny muscle here with a lot of fascia on the outer part of the leg. It's a major lateral knee stabilizer. See, the muscle itself is actually pretty small. You having a hard time? Is that, it's up to you guys. To me, it doesn't matter. Whatever is good for the class. Do you still see okay?
Yes.
Okay? Is that better? A weak TFL will sometimes allow a PI ilium, provides major lateral knee support. What's the other muscle that you might think would provide lateral knee support? Glute max provides lateral knee support. Also, sometimes you'll see a bowing out of the knee because of a lack of knee support. So TFL is related to the colon, and it's on the large intestine meridian. Nutrition is, I'm going to add greatly to this, but nutrition is acidophilus bifidus products, like lactans from the standard process. Fenugreek now, comfrey's been taken off the market. That was after the slide had been used forever. And standard has replaced that with okra. So you can't get, or at least that I'm aware of, you can't get comfrey anymore, but you can get the okra. It used to be comprapepsin E3, but you get the okrapepsin E3. Vitamin D, it's another vitamin D muscle. What's the other one? Quads. Those small intestine, large intestine are the vitamin D muscles. Your fenugreek products are Fencho from Standard Process and Fengray. Those are very good for constipation type patients. Fencho is also very good for detoxing the liver. Remember, the liver has over 500 functions, but if you could boil it down basically, it's designed to detox the colon. That's the basic function of the liver. It's kind of the coffee filter or oil filter of the bloodstream. Do I not eat liver? No, I don't eat liver because I can't stand the taste of it. I don't think it's a giant deal either way. I don't eat it because I can't stand how it tastes. Fencho is excellent for not only colon but also for liver detox. Fengray is more for just the colon. Lactans is a good acidophilus product. The okrapepsin E3, again, comfrey's been taken off the market. Also, many times a tensor fasciolata will respond to an anti-parasitic product. Parasites are becoming, in my opinion, more and more of a problem all the time. The standard product for that would be Zymex 2. Zymex 2. And you need to give that in between meals. Otherwise, the enzymes are used to digest the food instead of digesting the parasites. So when you give an anti-parasitic product, you need to give it in between the meals and for a couple of months. You need to get it through a couple of, like 2 life cycles, the eggs and things. So usually 2 months, and you give it in between the meals. Other good anti-parasitic products are Artisan, which has the Artemisia annua from thorn. Artisan, Berber cap, which has the berberis extract, Berber cap. That's also from thorn. Citricidin, which is the Paracan 144 product. Citricidin. Enterocap, which is a combination of Berber cap and citricidin, Enterocap. And there are others as well, but those are, you got 5 right there, so 4 from thorn and 1 from standard. That usually covers all the bases. There are, besides Entamedia histolytica and Giardia laminia, there are many hundreds of parasites, large and small, but it's becoming more and more of a problem. So just take a weak TFL, and if it strengthens to an anti-parasitic, give it. You give it for 2 months in general in between meals. Other unique products, Zymex, not Zymex 2, but Zymex from Standard Process. That's like the good soil for the colon, whereas the acidophilus are the good seeds. So Zymex, they also make it in wafers, Zymex wafers, which is good for a sore throat. You suck on it like a throat lozenge. Zymex wafers is like a natural antibiotic to clear up a sore throat. Okay, that's good enough for now. We're going to have, in session 8, we do the down the tubes lecture, and we cover from the mouth to the anus all the way down the digestive tract, but we'll kind of add to that as we go along. That's good enough for a start. John, you want to come on up and... Neurolymphatic reflexes are on the anterolateral thigh, the entire length, both sides, and sort of a triangular area in the back between L2, L5, and the PSI is kind of in a triangle shape. The neurovascular is the same as the glute medius and the quads, the posterior parietal eminence. This is a real good slide. The leg should be up a little bit higher, but in general, other leg is held neutral to stabilize here. Bring this leg up and out, turn the foot full internal rotation. John, I'm going to push towards the other foot. You go up and out the other way. Come on. Here. How about here? Push. Now, bilateral weakness, like we see here, that's related to iron deficiency. Now, if John is not a vegetarian, he's probably not what? Are you what you eat? No, you are what you digest and absorb. So I know you're not a vegetarian. So I know he's probably getting enough iron, he's just not absorbing it. Now think about it. What kind of internal environment do you need to absorb iron? Acidic. You cannot absorb it in an alkaline environment. So probably we want to check stomach function. Hiatal hernia, cardiac spasm, pyloric spasm, maybe a zinc deficiency, which is the most common deficiency there is. There's a good test for zinc that's a non-muscle related test. It's the zinc tally taste test, which Standard Process has. And when you mix up a solution and have the patient taste it, it should taste like rotten battery acid. That's a good zinc status in the body. And if they don't taste it at all, or if they just say it's a slight furry taste or a slight furry sensation in the mouth, that's a zinc deficiency. So that's one of the things that I used to do on every new patient is the zinc tally taste test. That's an excellent method for determining zinc status in the body. Okay. Zinc is also necessary for what, by the way, besides making hydrochloric acid? For making the CSF fluid electrolytic. Okay, the next muscle is one that you've already learned how to test, isn't it? The piriformis. You learned how to test that weight bearing yesterday. We did the piriformis gait inhibition test. This comes off from the anterior sacrum and goes into the greater trochanter. It's an extender, but mainly a lateral rotator. and realized that 1 out of 3 people, sciatic nerve penetrates the piriformis. Most sciatica is due to ileocecal valve, but it can also be due to a spastic piriformis. And if the piriformis is spastic on the right, how do you think the piriformis is on the left, usually? Weak. So you treat the weak muscle, check the spastic or shortened one for what? Fascial flush, a strong muscle that weakens after a gentle stretch. See how simple it is when you know how to do it? It's easy, most of the time. So here it is coming off the anterior sacrum. It also provides support to the anterior sacroiliac joint. Goes through the greater sciatic notch, and 1 out of 3 people, sciatic nerve penetrates the piriformis. I keep having the focus head. Is that automatic focus switch on?
Yep.
Good. Either that or I need an automatic focus on my glasses. Thank you. Now, here we see that the right piriformis is weak, and if the right one is weak, the left will overcontract. Remember yesterday the slide with the washer and the rubber bands? That's exactly it right there. That's it. We've shut the switch off on the right so that the left rubber bands overcontract, and the washer is the sacrum. I mean, that's that slide right there. It's a perfect example of that. That's not a bad thing to do in practice. Just get a washer with 4 rubber bands, put in your pocket. When a patient asks a question, a picture is worth 1,000 words. You can just demonstrate it. I mean, there's a real high-tech, expensive product. 1 washer and 4 rubber bands. I always believe in KISS principle. Keep it simple, not stupid. So just keep it simple. Keep your overhead low. Oh, lean and mean. Or at least lean anyway. No big overhead. Low overhead. The piriformis is one of the pelvic muscles, so it's related to the gonads, and it's on the circulation secretary. But look, it's not vitamin E, it's vitamin A. Test question. Test question. Piriformis is on the upper pews, TP of L5, and the posterior bridal eminence of the neurovascular, same as glute medius. Now, you already know how to test it weight bearing. This is how it's done supine. There's also a way to do it prone. So come on up, John. Yesterday we tested it weight bearing. And if you want to test it supine, you simply bring the leg up like you're going to do the rectus femoris test, but you stabilize the outside of the knee and pull towards the doctor this way. John, pull in. And that's a good one there. Pull in. Okay, to do it prone, bring the foot up, bring the knee out slightly, stabilize at the knee, stabilize the opposite side. John, you pull in, I pull out. That's the prone test. See how you can test it prone, you can test it supine, you can test it seated, you can test it standing. But when you test it standing, what's important? The knee has to be parallel, not lower or higher. Those are 2 different muscles otherwise. Okay.
Thank you. Stabilize under different than this.
Yeah, they show it a little bit different there. I like my test better, but that's fine. That one's fine. There's nothing wrong with that. Mine's a little more accurate. Semitendinosus is part of the hamstring, which is our next muscle group. So all the pelvic muscles are related to what vitamin? E except piriformis. You got it. The hamstrings are really a group, like the quadriceps are a group. You got the medial group and you got the lateral group. The medial group are the semitendinosus and semimembranosus. Semitendinosus comes off the ischial tube and goes into the pes anserine, the medial proximal tibia. The semimembranosus, again, comes off a slightly different portion of the ischial tube and goes into the pes anserine. Remember, pes anserine is SGT, sartorius, gracilis, semitendinosus, but also semimembranosus. The lateral hamstring group is made up of the biceps femoris, the long and the short head. The long head comes off the ischial tuberosity and goes into the head of the fibula. Very often involved with fibular head subluxation. Long head. Short head comes off the femur itself, but still goes into the head of the fibula. These are all knee flexors. The medial hamstrings provide medial knee support, and the lateral hamstrings provide lateral knee support. You can either get a valgus or a varus depending upon what's weak. Medial knee would be a valgus, lateral knee would be a varus, like a TFL would be a varus. Lateral hamstring weakness just in general can lead to a AF ilium, or diversified listing would be a posterior ischium. The hamstrings are related to the rectum. It's on the large intestine meridian. So if a patient had hemorrhoids, what muscle would you test? Hamstring. Hemorrhoids are usually due to, one cause, there's a secondary sometimes, usually due to congested liver. And if you think of it, the liver being the oil filter of the bloodstream, or coffee filter, whatever, however you look at it, whether you're coffee-oriented or motor-oriented, it's like holding a wet sponge up against the end of a hose, and all the pressure backs up through the portal venous system. So you either get hemorrhoids and or varicosities of the lower extremities. Usually it's a congested liver. Could also be weak adrenals. Usually it's congested liver. Nutrition is vitamin E. And if they cramp when you go to test them, you have to improve calcium metabolism. Not necessarily give calcium, but usually it's a hypochlorhydria. They're not absorbing their calcium out of their food. All women should take calcium to prevent osteoporosis. Not true. Not true. And osteoporosis has nothing to do with estrogen. That's somebody's big Newton of their imagination. If that were true, then men would be more osteoporotic than women. Men have far less estrogen than women. Far less. So what the heck does that got to do with it? Nothing. Okay, the reflexes are at the lesser trochanter and the TP of L5 posteriorly. The neurovascular is 1 inch up from the lambda on the sagittal suture. This is a pretty good test, except what's he doing wrong based on what I told you yesterday?
I think his elbow.
His elbow is bent, and look where he's stabilizing. He's pushing, of course he's doing that so you could, in all fairness, he's doing that so you could see the muscle, but never stabilize over the pelvis. You grab the belly of the hamstring, but if you did that, you couldn't see the muscle. But anyway, you don't push here, you just grab the hamstring belly to prevent cramping. And the best way to do that is with the foot not in plantar flexion. Why?
Recruits the gastroc.
Because you recruit the gastroc. You want the foot neutral, not in plantar flexion. And you don't want it in dorsiflexion either, but just neutral. John, come on up. So when you test these, I learned this from David Leaf, when you test these, put just in neutral, stabilize over the belly, grab down here with my elbow straight, push with your body. Push. See, that's the weak one, as a group test. Push. Now watch this. Don't do it this way. Push, push, push. Actually, that's a real weak one. A lot of times, you'll find it strong here, but weak here. It can be fine in both ways. But you'll miss half of them that way. Now, watch this. To do the medial hamstring, point the toes towards the side you're testing, let the foot come out lateral. Now you're testing the medial hamstrings. Push back, push, push, hard. That's medial. To test the lateral hamstrings, point the toes lateral, bring the foot medial, and push, push. That's the lateral hamstring. So the toes will point to the side you're testing. Toes medial, you're testing the medial hamstrings, and toes lateral, you're testing the lateral hamstring. But keep that elbow straight. On him, it didn't matter, but a lot of times it does matter. You'll miss it over half the time. Most people don't test the hamstrings right when I'm watching it. I always know my students when I'm at the annual conferences, they're all like, yeah. And don't, in the pictures in the book, see how that foot's plantar flex? That's bad because they can recruit the gastrocs that way. Don't let them plantar flex. So here's the lateral. That's a great slide just to show the muscle. Here's the medial. Okay, the glute max that we tested on Alan yesterday with the high nose. There's actually 3 divisions to the glute max. It comes off the sacrum, it comes off the ilium, and the coccyx. So there's actually 3 divisions to the glute max, and it comes into the linea.
Aspera. Aspera.
See, look. Coccyx, sacrum, and ilium. There's 3 divisions. Fibers come down into the linea aspera. Did I say Alma?
Yeah.
No, linea aspera. And on the femur, it's the major hip what? Extender, but also lateral rotator. But it's the psoas is the main muscle that brings the leg forward, and the glute max is the main muscle that brings the leg backward. So if you have a weak psoas here, what do you think that glute max will be? Hypertonic. And if you have a weak glute max here, how do you think that psoas will be? Hypertonic. See, it's that washer with the rubber band concept again. I'll show you all that. That's many different things. We'll show increased range and flexion all year long. From stuff will blow your mind. You'll say, how could that do that? But it does. Show that. But if you have tight hamstrings in general, what's your name? Michael. If you have tight hamstrings, what do you think's weak? Quads. Well, tight hamstrings is weak quads. You got to figure out why the quads are weak. But we'll show that all year long. Any tight muscle, look to the antagonist that's where the weakness is. And runners should not stretch their hamstrings before they run. They should stretch their rhomboids. That woke me up, see? That's true. They stretch the wrong muscle. They should stretch the rhomboid. I'll show you that. I learned that from Dr. Goodhart. Now, where was, oh yeah, glute max. So it's the major hip extender. Weakness will allow high iliac crest and an AS or posterior ischium.
Dr. Francis? You have
Yep.
a question right here. I don't think it's not, I don't want to see my question.
Go ahead.
You said the glute max is the ultimate lateral knee stability earlier?
Yeah, the glute max provides lateral knee stability along with the TFL. Remember, muscles move bones. 650 muscles plus or minus. 210 bones plus or minus. Okay, this is one of the pelvic-related muscles, so what vitamin is it automatic? E. What meridian is it automatic? Circulation sex, you already know that. A bilateral glute max weakness is an upper cervical fixation. So if it's weak both sides, that's an upper cervical fix. So VJ was right in a lot of ways. Now, look at the neurolymphatics. What is that the same as? Same as the TFL, the anterolateral thigh, posterior TTL5. But the neurovasculars are the lambdoidal suture, midpoint on lambdoidal suture. Here is a beautiful slide of the glute max test. Beautiful. Okay, John, come on up. The important thing here is that you want to take off the extensive properties of the hamstrings so you have that foot flexed up as much as you can. So you bring the foot all the way up here, and what they'll do when they try to recruit is they'll want to extend that back out to recruit the hamstrings. So you bring that foot all the way up. The other thing they'll try to do is they'll try to rotate the pelvis up. So a lot of times you can pick up a weak glute max just by observing body language. Lift your knees straight up. Now, push up, straight up. That's a good one. Okay. Stand here. Lift your knees straight up, all the way. Push up. Now I knew that was going to be weak when I watched him lift it. Watch him lift it. Lift it. Oh, come on. See what he does? I already know it's weak. A lot of times you can glean more information just by observation than even the actual muscle test. Raise it straight up. Straight. He doesn't want to do that. Push. Now, that's weak. What's nutrition? Vitamin E. High dose? Not necessarily. Could be. Could be. But he might need the one, or he might need the other kind, or he might need both. I'm not prejudiced one way or the other. Just give the patient what they need. Either way, doesn't matter. But diagnose the need. Then supply it. Then observe it. Okay, so let's flex our biceps. And why don't we break up into two groups? I'd like, of course, the TAs to stay. And if you guys could each take a row. And what we'll need is all the books, water, keys, pens, standard bars, off the table. What we're going to do is military style, one down, one up. And why don't we take like half the class, take a wee break for about 15 minutes or so, then come back and we'll switch. Okay, so elbow straight, full internal rotation. Stabilize the opposite acis, come below the wrist with a broad contact. You're going to push, let it go up. You're going to push in a vector opposite the acis, so out like that, out and up. So have them start the test. Go ahead, push, 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 and push. Okay, very good. Now, excellent. Don't move. Don't move. Try to keep the talking to a minimum just because it's easier for me. Now, hand in about, arms in the same position. Take your hand from the acis up to the shoulder. Now you're going to pull out and slightly down for the pec major clavicular. Out and slightly down. Rob, go ahead and push. That's a good one. That's pec major clavicular. Okay? You have either need to be down on the table or muscle testing unless you're a TA. So. If you're not a TA and you're not a patient and you're not muscle testing, please leave the room. But I need to keep it organized. Please. Okay. Now, let's do the next muscle. Let's do the quadriceps. And if I forget one, would you guys remind me if I forget one. Now, bring the opposite knee up, hands off the body, right next to the patient. This is a big, powerful muscle, so you need to be right in with your body. Take a broad distal contact on the tibia. Look where my elbow is. Look where my elbow is. Pay attention. Not this. My old karate instructor instincts come out now. Not this way. This way. Not like this. Light up. Push, push. Okay? Now, let this one go. We'll do the rectus femoris. Position it here. Look at my arm. Notice whenever I muscle test, what do? My arm and body are always in the vector of the test. Grab the knee, grab the ankle. I'm going to push down. Rob, you push up. Push, 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 push. Good. Okay, excellent. Now, let's bring it straight up 30 degrees. Stabilize just below the opposite acis. Push up. Don't let them bend the knee.
I can't even hold.
Now, same position. Bring it out 30 degrees. That's the psoas. Don't let them dorsiflex the foot. Hold it there. Push, push. Straight down. That's the weakness. What they'll do is they'll rotate the pelvis up. Now, come down to the end of the table if you can. If not, just do the best you can. Stabilize the one. Bring the opposite one up. Knee straight. Full internal rotation. Let's all do the right TFL. So we're all doing the right TFL. Let the other one on the table. Up here. Push towards the other one. Rob, push up and out. Too much red meat, maybe. Push up and out. Okay. Right on the side. Stabilize on the edge of the table. This hand off the body. Bend the knees like this first. Keep the pelvis perpendicular to the table. You're going to stabilize at the pelvis. Bring the legs straight on top. Don't allow them to externally rotate. Bring it straight up. Push, push. Push, push. Don't let it rotate back. Here. That one's weak, I'm pretty sure. Bring this one up, bend your knee. So that has to be perpendicular to the table, tibia is parallel, and stabilize the outside of the knee. I'm going to pull out, Rob. You pull in. That's a good one. Excellent. No, grab it this way. Bring the knee up higher. There. Now. Okay, let's all go around the other way, so we're all doing the same. Just move those chairs in or out. Any other ones I forget? Is that all of them? Okay, let's have the patients go prone. Yep. Okay, do the hamstring closest to you. We're going to do it as a group first. So now, when you have them lay face down, don't let them do this. Don't let the hands cross or touch each other. So, bring the one closest to you up about 45 degrees. Here's a common mistake. They bring it too far up, they'll have a false negative and the hamstrings will cramp. So bring it down about 45, foot's in neutral, not plantar flex or dorsiflex. Grab over the belly of the hamstring, grab the distal portion of the tibia, lock your elbow, lock your elbow, lock your elbow. Now have them push back hard, then you push down. Now don't move. Don't move. Put the toes in, foot out. That's what hamstring group. Medial. Now push down and out. Lock your elbow. That's a weak one. Lock your elbow. Lock your... Now, point the toes there. Point the toes out. Bring the foot in. What muscle are we testing? Lateral hamstring. Lock your elbow, push down and in. Excellent. You guys are doing great. Now, bend the knee, bring the knee straight up, and stabilize over the pelvic area, push straight down at the glute max. Now let the knee down, bring it out a little bit from the midline. I like to put my knee to the outside, stabilize the opposite thigh, knee is on the table. Bring the foot slightly in, grab the distal ankle and pull towards the doctor. That's the prone piriformis step. Did I miss any? Was that? I think that's opposite knee. So you're going to support the leg here. Knee is almost extended. Get the body close. Elbow up. Push in a geometric fashion. Down and in. You push up. That's the quadriceps as a group. Now, let the other leg down. Bring the knee up. This is parallel. This is perpendicular. Over the knee, grab the ankle. You're going to push down towards the table. Push up. Push, push. Okay, now please. Right from there, bring the foot in. Stabilize the outside of the knee. Grab here. You're going to pull towards the doctor. That's a supine piriformis. Now, right from there, let it down. Please. Full external rotation. Knee is extended. Bring it straight up, 30 degrees. Straight up. Stabilize just below the opposite acis. Push straight down into the table. That's the iliacus. Don't let him rotate the opposite hip up. Don't let him bend the knee. Now, go back to the start position. Go back to the start position. Don't let him dorsiflex. Bring the leg out, abduct 30 degrees. Ask him to hold. Push up. Push straight down into the table. Now, go down to the end of the table. This leg is straight. This one is fully extended. Full internal rotation. Bring it up and out. Push towards that foot. The other one, push up and out. Push up and out. Go ahead. Okay? Let's have the patients turn over. You guys are doing good. Okay. Bring the foot up, closest to you. You're on that side of the table. 45 degrees. Foot to neutral. Grab over the hamstrings. Grab the distal tibia. Lock your elbow. Lock your elbow. Have them push up. No, don't do it this way. Do it this way. Push back. Now, don't move. Point the toes to the midline. Bring the foot out. Push up. That's what? Medial hamstring. Don't bend the elbow. Medial hamstring. Now, point the toes. Bring the foot in. What are we testing there? Lateral hamstrings. Lock the elbow, push down and in. Lock the elbow means don't bend it. Okay. Then the foot up. Ask them to lift it straight up. Stabilize over the pelvis. Push down and in on the distal femur. That's the glute max. Get a distal contact. Distal. Get right near the knee. Otherwise you'll miss it. It's the strongest muscle of the body. No, don't do it that way. No. Bring it up, lift it up, stabilize here, push here. Okay, now let it down on the table, bring the knee slightly away from the midline. Stabilize the opposite thigh, bring the foot in, pull in. That's the prone piriformis type. Guys are doing good. Okay, let's get this group out, new group in. Okay, so patients heads this way, feet that way, no chew gum, no suck mints. Hands off the body, watches off if they're battery. Develop a good habit now. It's like a good tennis swing. Start right, off right, you don't have to change it later. You guys ready? Ready?
Does a watch on the doctor have any effect?
Not usually.
One for a pair.
Okay, you ready or not?
Everyone else?
Hands off the body, hands off the body, hands off the body. Come back to the room here, pay attention. Okay, doctor, you guys ready? Okay, bring the arm closest to you up. Full extension, full internal rotation. Stabilize the opposite acis. Take a break, a little bit. Here's a common mistake. If they'll bring it in too close to the body and you'll miss it. So right about here, take a broad contact over the distal arm. You're going to push in a line of a vector opposite the acis, in line with the fibers. Push back hard, hard, hard. That's the weak one. Go ahead. Okay, now, don't move. Bring that hand up from here over to the shoulder. Now you're going to pull out and slightly down for the pec major. Take a more distal, Carl. Take a more distal contact. You're going to push out and slightly down. Go ahead, push. That's pec major clavicular. Okay, excellent. Now, come on, let's go. Bring the opposite knee up. Okay, you need to, it's one per person, so you need to find someone else. Hands off the body, hands off the body. It's paired, not three at a table, it's two. One up, one down. Now, bring the leg up closest to you. Hand over the knee so that you can support the one you're going to test right on top, not here, right on top. Get your body right next to it because it's a big, strong muscle. Now, take your contact on the distal tibia. Look where my elbow is. It's not like this. Do like this. Not like this. Do like this. They push up, you push down. Okay, let that one go. Bring the leg up so it's perpendicular to the table. Tibia is parallel. Get right in front of the top of it. Grab over the top. Grab the ankle. You're going to push down towards the table. They push up. Bring it up a little bit more. There you go. Push up. Push, push. That's the rectus femoris. Now, bring the foot in. Stabilize the outside of the knee. You're going to rotate towards the doctor. They rotate in. That's the supine piriformis test. Now, let it down. Full external rotation. Knee is fully extended. Bring it straight up in the midline, not across, but straight up in the midline. That's the iliacus. Stabilize opposite the acis. Ask them to hold it right there. Foot's neutral, not dorsiflex. Push straight down towards the table. That's the weak iliacus. Now, Don't move. Bring that up. Iliacus, bring it out 30 degrees. That's the psoas. Push up. That's the psoas. Guys are doing great. Now, get down to the end of the table if you can. If not, just get down along the side. This foot straight. This foot straight. Knees extended. Full internal rotation on the right. Their right. Bring it up and slightly out. You're going to push towards the opposite foot. Do his right side. And push up and out. Push up and out. Good. Now, have the patient lay on their side facing the front. What was that? Tensor fascia lata. Face the front. Patient facing me. Now, stabilize at the table. No therapy localization here. The bottom leg is bent to stabilize. The pelvis should be perpendicular to the table. Bring the leg up, knee straight. Don't let them externally rotate. Stabilize at the pelvis here. Push up. That's a weak one. No. Look at this. Don't do this. Do this. Don't do this. Push up. Push up. See the difference? Lay face down, patients, please. Don't let your hands cross. Now, bring the foot up closest to you, about 45 degrees. Foot is neutral. Don't let him plantar flex. Grab over the belly of the hamstring. Grab the distal tibia. Lock those elbows. Lock the elbow, which means you have to move your body up here a little bit. Push down towards the table. They push back harder. Don't move. Don't move. Point the toes medial. Foot out. What are we testing? What are we testing? Medial hamstring. Lock the elbow. Push down and out. Don't move. Point the toes out. Bring the foot in. What are we testing? Lateral hamstrings. Lock the elbow. Push down and in. Now, don't move. Bring the foot all the way up. Ask them to raise the knee straight up. Stabilize at the pelvis. Push down and in towards the table on a distal contact. That's the gluteus maximus. Now, don't move. Bring the knee slightly away from the midline. Bring the foot in. Stabilize the opposite thigh. Pull towards the doctor. That's the prone pulling. That's the prone piriformis test. Excellent. Let's have you switch, doctor, patient. New patients face up. Videos available right now from a couple of years ago, and they're the same price. If you want to buy those now and then to upgrade, we can work out some kind of, just the cost of what it was for the production maybe or something like that if you want to do that. The videos from a couple of years ago are very good. I don't think they'll be as good as these, but
I was wondering about
I didn't hear you. What?
Oh, I was wondering if at any point if you're going to make available any kind of patient education video.
I'm going to make available, I have about 10,000 projects right now that I'm working on. That's probably one of them. But I wouldn't hold my breath if I were you. I have a video that one of the times when I was on a local Las Vegas health TV show, and I give that to the new patient to take home and watch. It's much better if you make your own video for your patients rather than seeing a different doctor. But you're welcome to get a copy of that from Dorothy. I think it's like $20 or something. If you just want to, I was on a local TV thing a long time ago. On the supine piriformis test, you can do it either way. Rob, you want to just... If you want to bring it up here, pull in. You can do it here. Sometimes it's a strong muscle, so I like to pull from here. Just don't challenge the ankle joint. You have to be careful of it. Pull. You just don't want to make sure not to challenge the ankle. So overall, real good on the workshop. Let's go ahead and cover the next subject now. Oh, there was one thing before I forget, announcing seminars. I'm doing an extremity seminar. Dorothy is here? Yeah, could you, I know you're there, could you come in here? What are the dates for the, because I've only got like 2 seats left for the Dallas seminar on the extremities. Okay, so if anyone's interested, there's only 2 seats left. They're usually sold out way ahead of time. I don't advertise them. But there is December 15th and 16th in Dallas at the Embassy Suite. The cost of the seminar is $433, and it's limited to 24 people. And we're about 5% lecture and 95% hands-on. How many here were at the Santa Fe seminar? So if you want to talk to one of the people who had their hand Santa Fe seminar, could you guys find that? Okay, I'm glad we rehearsed that earlier. But anyway, if you need it, you get 12 hours of license renewal through Logan Postgrad. So if you need the 12 hours, you got 12 hours of license renewal through Logan Postgrad on the of the knowledge.
In my own interest, I will be giving a talk on November 4th with a biochemist about a particular product that was going to, really, the announcement that we're doing where it's going to change health for generations to come. So if you're interested in that, call that toll-free number.
Just some other announcements about the ICK has an annual meeting every year, and I would definitely highly recommend you attend it. Last year it was in Palm Springs, but it's usually every June. And we also have regional meetings, like either fall, winter, or spring. And this winter regional meeting is for the ICAK is February 2nd through the 4th, 2001 in Dallas, Texas. It's also at the Embassy Suites. Their number at the Embassy Suites is that's wrong, I'm going to be able to block the punches, the kicks, and the strikes. Then you start putting that together in forms. Then you start doing 3-step fixed attacks, then 1-step, then semi-free, then freestyle. Then you really start to learn. But you can't do that if you can't even get into a front stance or a back stance or whatever. So it's kind of like that. You kind of have to take it step by step, and that's what the method of my madness is. I do have a method for doing that. It works pretty good. So if you just kind of follow along, monkey see, monkey do, and I think it'll work out pretty good for you. So,
Along the same lines, I just wanted to mention that this course is quite a bit different experience than what you have in school. In school, I was very used to kind of going with the flow, showing up to class, kind of going through the motions, and then cramming it at the end for the test.
Yeah, don't do that.
Yeah, can't do that here. Please keep up with this information. Even if you think you got it, you heard it once, workshop it at home and at school. Grab people out of the hallway, start working on them. Get really confident with this weekend's information, because it'll really take off down the road, and you really need to be ready for it. If you wind up at the end cramming for this test, you're not going to have a good time. Just keep up with it, and you'll learn it, and you'll be really good. Last thing, if you get good at any kind of any chiropractic technique, your patients will get results, and they'll refer people and stuff like that. I've been to a lot of practice management and practice building type of seminars, and you're going to hear a lot of promises from a lot of different people. The difference is if you get good at this type of approach, where you can help someone holistically, you're going to even have other doctors referring you their difficult patients. That's a major difference. I mean, the patients referring their friends is just a done deal. But having other doctors in the area referring their patients to you to get them over the sticky stuff that they don't know how to fix is really invaluable. So keep up on it, please.
AK is like boiling water. If not given continuous heat, it soon becomes cold. Now, I borrowed that from Funakoshi on Karate do Kyohan, but it is how it is. Okay, let's get the lights on. Our next topic is challenge, and therapy localization tells you where the problem is, but not what the problem is. Challenge will tell you on a structural level what the problem is. Pretty simple. Let me talk about it, then we'll go through the slides. We'll talk and show it again. Now, in the spine, you have intrinsic muscles called rotators, longus brevis, interspinalis, intertransversalis, multifidus, and so forth and so on. But it's really the rotators, longus, and brevis that are involved in what we call the rebound phenomenon. Just listen for a minute. If you take a spine, if you palpate a spinous process and it's to the right, if you challenge it dynamically by pushing on the spinous right to left and then let go, you do to the intrinsic muscles, it rebounds further into lesion, which will cause a strong indicator muscle to weaken. If you've got that, you've already got it. That's basically it. So if the spinous is right, and you push on it to the left and let go, it rebounds further to the right and causes a strong indicator muscle to weaken. So how would you adjust it? In the direction of challenge, from right to left. That's it. It's that simple. So if you got that, your whole understanding of my discussion from this point on will be easy. And if you don't, you're going to be lost in la la land without a machete. One more time. If the spinous is right, it's because the muscles on the right are hypertonic and the muscles on the left are hypotonic. You push the spinous from right to left. If you let go, it rebounds further into lesion. That would cause a strong indicator muscle to weaken, and you need to adjust it from right to left. Got it? Okay, now that's going to be true for the sacrum. That's going to be true for the pelvis. That's going to be true for the occiput, or the atlas, or T2, or even a rib head. The rib heads have intrinsic muscles called what? The levator, costorum, brevis, and the last four ribs also have a longus. So even the rib heads rebound. So if you challenge a rib head superior and let go, and it weakens a strong indicator, how do you adjust it? Right, you adjust it in that direction. Okay? In the spine, there is what? A rebound phenomenon. And that is because why? The intrinsic muscles. Test question. So in the spine, we have a rebound phenomenon, and that's due to the intrinsic muscles. The rotators longus and brevis for the vertebrae, and the levator costorum longus and brevis for the rib heads. But outside of the spine, do we have intrinsic muscles? No. So do we have a rebound phenomenon? No. So in extremity challenges, there is no rebound phenomenon. In the extremities, there is no rebound phenomenon. And did you know, in the extremities, there is no rebound phenomenon. And furthermore, did you know, in the extremities, there is no rebound phenomenon. Somebody will miss that question on the test. No. That's only based on giving the test 20 times before. Okay. So let me show you, and then we'll go through the slides. and then we'll talk about it again, and then do a workshop. Okay? So what does a therapy localization do? Tells us where the problem is. What does the challenge do? Tells us how to fix it on a structural level. Okay? So anybody with a vertebrae, come on up here. Yeah, anybody, come up here. Okay, so let's do a quick postural analysis. You go ahead and put the light back if you don't mind. And turn face this way. Just look straight ahead, eyes open. So what we're doing is a static postural analysis. And, okay, he's got a high left iliac crest. So when your iliac crests are not even, when one is higher than the other, that's an indication for what we call a category 2 pelvic lesion, which are the categories coming from SOT. SOT is part of AK. So when the iliac crests are uneven, we have a category 2, which is an osteoarticular problem. We're going to talk about that at session 2. But it will therapy localize. Now, let's have you lay on your back. He's got a short leg on the left. Bring this up. Put it up front. Heel the left SI joint. Push up. That's a positive therapy localization. Heel the right SI joint. Push up. But negative on the right. So where's the lesion? On the left. Does it tell me whether it's TI or AS or EX or IN? No. That's the challenge. Okay? Now, turn over. Turn over on your back. I know I always get the complicated ones. Okay, well, he's got a short leg when he's supine and a long leg when he's prone. When you see that, that's an atlas. So the short leg goes to long or long to short, from supine to prone, that's an atlas. If you see short to shorter or long to longer, that's an occiput. So for demonstration purposes, come on up. Face that way. Have a seat. Now, bring this up here. Push up. Bring this up here. Push up. Okay, take your thumb, TL the atlas on the right. Don't push, but just TL. Push. Push. Okay, so what does that tell me? We have an atlas. Does it tell me how to adjust the atlas? No. So then, okay, so now I'm going to use the challenge to tell me how to adjust the atlas. Is it okay? In fact, stand up just for a second. I'm going to pull this back just a little bit. Now, push up. Sit up. John, you're all messed up. Push up. Okay. Now, what I'm going to do is take a contact on that side. I'm going to just challenge it. 1, 2, 3. Let go. Push up hard. Now, which way do I adjust it? In the challenge direction. Why? Because of the rebound phenomenon due to the intrinsic muscle. Got it. Now, there's no rotator as long as in brevis up here, but those are the suboccipital muscles. The rectus capitis posterior, major and minor, and the obliquus capitis superior and inferior, and the rectus capitis lateralis. So there are intrinsic muscles up here, they're just not the rotator as long as in brevis like for the rest of the spine. That's in your workbook. Come down a little bit.
Could you show how you challenged it again?
Sure. Just, you take a contact, you set off on it like you're going to adjust. Don't thrust hard, but just thrust 2-3 times challenge it, and then recheck your strong indicator. Whether it's a quadricep, a deltoid, a pec major sternal, whatever muscle you want to use as an indicator. You feel. We got a nice double release. Sit up tall. Bring this one up here. Push up. Take your thumb. Heel, don't push, but just heel. Push up. Okay, come on back up here. Knee up straight off the table. His legs are now even. Turn over. His legs are now even. Turn over. Bring this one up. Push up. Heel the left SI. Push up. What does that mean? That the category 2, in his case, was compensatory to the atlas. It's not always that way, but it was for him in this case. Okay? But when you see that, I didn't know that was going to happen, but it was good knowledge. Short becomes long, or long becomes short, from supine to prone, or prone to supine. That's what? Atlas. And if short becomes shorter, or long becomes longer, supine to prone, or prone to supine, that's occiput. Okay? So any questions on challenge? I mean, it's really that simple. Eric, your liver is all congested.
Yeah, we went over some already.
Okay. Pelvis also has rebound. Come on up. Take off your watching glasses. You also have an upper cervical fix. Now, lay on your back. You have weak abdominals. He's got a short leg on the left, so it could be what, a PI left or an AS right. Turn over. He's now got the opposite up. Now he's got a short leg on the right. So what does that mean? Probably atlas. Come on up. I was trying to show something else, so let me get some. I wanted to get a pelvis up here. Sure. Come on up. And he's probably lateral on the left. Things work out. Lean your back up here. And if you have an atlas, what do you know that he has? TMJ. If you got TMJ, you got atlas. They go hand in hand, kind of like the egg and the chicken. She's got a short leg on the left. Turn over. Thank God, and it stayed short on the left. Okay, now, turn back over. Okay, and take your watch off. Are you on any medication at this time? And if a patient is on medication, don't make a face or any of that. Just say, okay, and put a tablet of RNA under the tongue. But if they say they're not on any medication, say good. Now, bring this up here. Push up hard. Heel the left SI. Put that down. Push up hard. Hard. Okay, that's a positive therapy localization over the left SI. Let's try the right SI. Push up hard. Put negative over the right. Does that tell me how it's subluxated on the left? No, so we use challenge mechanism. Turn over. The challenge mechanism is unerring. It's perfect. Now, bring this foot up here. Push back hard. Bring this one up here. Push back hard. Bring this one in. Push in hard. Oh boy. Bring this one in here, push in hard. I'll use that as my indicator. So always start with a strong indicator, otherwise you end up in la-la land without a machete. Let it go. So we had a positive on the left. We had a short leg on the left. So I'm going to just do a static palpation. We've got a lower PSS on the left. I'm going to do just some minor motion palpations. She has more motion to EX than to IN. So I'm thinking it's a PIEX. But the challenge will tell us the exact vector. So I'm going to challenge in the direction I would want to take it and find out. So I'm going to challenge I to S lateral to medial. And I do it 2 to 3, 4 times. That overrides the cerebellum. And hard. So what does she have? She's got a PIEX. That tells me the exact vector to take it. Okay? Now okay? Okay. Good. I'm not going to fix it. I just wanted for demonstration purposes. Okay? Now, any questions about the spine? Have you got it? It's actually pretty simple. Okay. Is it like it'll ruin your day if I explain the extremities? Do you want to wait till session 2? How many want to wait till session 2? Okay, well now no one's going to do that, okay. So, all right, we're just going to explain now. Are there intrinsic muscles in the extremity? No. Is there a rebound phenomenon? No. Okay, so now put your thinking caps on. Okay. It depends on, now in the spine, you always start with a strong indicator. Yeah. Yeah. Always with the spine, start with a strong indicator. But not in the extremity. Now put your thinking caps on, real tight. Now, it's actually pretty simple. Let me give you an example. Rob, come on up. He's got a posterior tibia on the left, so lay into that. Now, let's say, let me tap, I'm just going to walk around and tap this. Push up hard. Push up hard. Okay, now, we're starting with a weak muscle, correct? We have a weak quad on the left. I'm going to challenge this proximal tibia, T to A. Okay? Are there intrinsic muscles? No. So is there a rebound phenomenon? No. I'm going to just challenge that. Come back up. Push up. And we got a strengthening effect challenging the proximal tibia. This is why I don't wear one of these in the office. T to A. And it strengthened the weak quad. Think, how would we adjust it? T to A. You got it. Because there's no intrinsic, there's no rebound. If you're reducing the lesion, you get a strengthening effect. That's right. You got it. That's class I taught yet. You got it. What if you started with a strong muscle? Let's take the opposite quad. We'll start with a strong muscle, push. And what if we challenged it A to P, the opposite? Push. And it weakened your strong indicator. How do you adjust it? The opposite. Why? No intrinsic muscles, no rebound. You got it. You got it. So if we adjust that, it's okay. Push. That takes care of it. You got it. You guys got it. No problem. Turn the lights on. Somebody's watch is up here. So I'll run through the slide. Pairs of spinal nerves, 24 movable vertebrae, 2 primary, 2 secondary curves. This is the beauty of it. Here's the rotator's longest, or brevis rather, that runs from the lamina to 1 TP below. The rotator's longest runs from the lamina to 2 TP below. If you have spinous left, remember the washer with the rubber band concept. We turn off here, we hypercontract here, pull spinous left. Those are the intrinsic muscles. If we push from left to right and let go, it rebounds further into lesion due to the intrinsic muscles. And creates a weakening effect on our strong indicator muscles. So we would adjust from left to right. Work the muscles. So sometimes you need to do origin insertion to the rotator's brevis or longus. Don't do that on every subluxation, it's not necessary. But if you adjust it more than 2-3 times, do that. Muscles and bones. Now, are you clear on that? Because now I'm going to give you a ringer. On an anteriority, and yes, they do exist, and I love clearance, but anteriorities do exist and do create problems. Can you get in front of the spine to push it A to P? Well, not an alive person, or I wouldn't recommend it anyway. So generally not. So, listen, instead of a dynamic challenge, which is pushing and letting go, we now do a static challenge, and we hold the bone into lesion. So you take a contact and hold it more anterior. You do a static challenge and hold it. If it weakens on a static challenge, then you adjust opposite. You're doing this. The only time you really need to do that is with the anteriority. Okay? Rob, you might as well come up. Lay face down. So just watch, it's actually not complicated at all. We're going to take a strong indicator muscle, lock, push. Now, TL, T2. SB, don't let your hands touch each other. Push. Push. Now, what does that do? It tells me where the lesion is. Now what do I got to do? Use the challenge to tell me how to correct it. So let's say, I just go to T2. I'm going to push right to left. Push. Nothing. I'm going to go to T2, push left to right. Push. Push. Nothing. Maybe it's anterior. Can I get on the front of it and push it A to P? No. So now we use a static challenge. I'm just going to hold it P to A and tap. Okay. So I'm I'm going to get right on the spinous of T2. I'm going to hold it. I'm going to hold the anterior and push. Push, nothing. So how do we need to take it? A to P. So we're using a static challenge. Generally, we only do it with anteriors. I'll show you a little trick with T2. You ready? This is additional knowledge. It's not actually written anywhere. Lay your back. He's going to have what Dr. Frank calls in TBM cardiac low back. I am not sick. I am not teaching TBM. I'm simply showing a correlation. Put the feet together. Bring this up. Hold it there. Push up. For those that have had TBM, that's what he would call or label cardiac low back. Come on up. Face that way. Yeah, face that way. We'll also have, very often, a weak hold, a weak subscapularis, one or both. Okay? Now, the way you take this is, it's an little osteopathic maneuver. Face that way, put your feet together, put your hands up here. I'm going to get behind them like this so that my thenar eminence is on both occiput. Put your hands on top of my hands. Now, head back just a little. Now, leave your feet where they are. Let your body fall with me. Kind of traction back, just like that. And that brings that T2 back. Anteriorities are easy in here, aren't they? But it's a little harder on 1 and 2, maybe 3. That's how you do that. That's one way. Have a seat. Push. 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 Now he's ready to arm wrestle. Wait. Push. Lay in your back with your head here. Lay on your tummy. Chiropractic works. It works every time, and it's not just for musculoskeletal. The first chiropractic patient was not musculoskeletal or neuromusculoskeletal. Bring this up here. Push back hard. But it works good also for musculoskeletal. Same thing. Push. And it says, yeah, man, you got it. Okay. So any questions on anteriors? What type of challenge do we use? Static. Okay. You got it. Basically, you got it. So we're going to workshop that in just a second. Those vertebrae actually look like they've been in the freezer for a while. Muscles move bones. Sometimes we need to do organ insertions in the levator caustorum for the rib head. Okay? That's in your workbook. Do the rib heads rebound? Yes. Why? The intrinsic muscle. Do you go in the dynamic challenge direction? You also have intrinsic muscles for the upper cervicals, the obliquus capitis inferior. This is in your workbook. The obliquus capitis superior, the rectus capitis posterior major, and the rectus capitis posterior minor, which, by the way, is continuous with what? The dura mater in research. And the rectus capitis lateralis. Now, turning your workbook to the Lubbock reactor. I want to finish this in the respiratory. and then you're going to workshop, and then I'm going to take somebody, and then we're just going to kind of go through them. John Molly. You need it. Like, you know, but you a little more right now because of the reactor. Now, so what we call the Lovett reactor or Lovett brother simply states that if there's a relationship here, there's one below. So oxygen goes with sacrum. It's right in your workbook. C1 to L5, C2 to L4, C3 to L3. Now, up to that point, you have same rotation. But from that point on, you have, right in your workbook, opposite rotation. So C4 to L2, opposite. C5 to L1, opposite. C6, T12, opposite. Okay? That's right in your workbook. What it means is, if you have an occiput out on the right, what else are you going to check? Sacrum on the right. If you have C4 on the right, what else are you going to check? L2 on the opposite. Okay? Not that it will always be there, but oftentimes. That's one thing that causes a recurrent subluxation, is that you didn't fix the Lovett brother. Okay? Down to C3, L3. It's right in your workbook that way. No, C3. And the sphenoid goes with the coppice. The sphenoid is the center of cranial motion. 12 other bones articulate with the sphenoid. But do bones move bones? No, muscles move bones. Upper trap, SBM, and the temporalis, master, internal third, right, external third, the TMJ muscles. Anyway, you have a Lovett, that's all there is to it. So if you have a C1, where else are you going to check? L5. If you've got a T5, where are you going to check? Opposite T6. T4? T7. You got it. That's all there is to it. I don't even need to demonstrate that. It's just self-explanatory. Okay? So the same movement is down to C3, L3. And then there's the opposite after that. You've heard of sacro-occipital technique? That's a Lovett brother. Sacrum occiput. That's where the dura attaches. Now, the last one is on the last page. That's called a respiratory adjustment. And then you have a glossary of terms, which is actually kind of handy. Now, I'm a big bone mover, and I really believe in setting bones. See, D.D. Palmer did not discover that, did he? We've had bone setters in Asia, and bone setters in Europe, way before D.D. Palmer. But what he did is he formed a new profession, which he labeled chiropractic. There have been bone setters forever, okay? But sometimes you may want to use a non-high velocity technique. For example, somebody that's just very sensitive, what we call ligament stretch syndrome, which we'll cover next time in session 2, where a high velocity adjustment is actually contraindicated. Like for example, in your case with the hypermobile SI joint and very sensitive SI joint, that's a ligament stretch syndrome. That is a contraindication currently right now for a high velocity. It may not be that way 2 months from now, but right now it is. When you get a high velocity, you probably get worse. Feel warping. So there are times when you want to use a low velocity technique, and that's this. That's a respiratory adjustment. And you simply do the same adjustment, but you don't use high velocity. You're moving it without high velocity on a phase of respiration, either breath in or breath out. Come on back up for the category 2 with the washout. She had a PIEX on the left which therapy localizes on the left. Lean your back with your head up here, feet down there, body in between. So we'll take a strong indicator muscle then. You push up, I push down. Scale the left hand side. Push up. That tells us where it is. Turn over. Bring this up and in. Pull in. Hard. Okay. Let's challenge that. Pull in. So that tells us how to move the ball. Now, when you want to use a respiratory adjustment, on the challenge, have the patient take a breath in and hold it, or have them take a breath out and hold it out. Go in the challenge direction on the phase of respiration that negates the challenge. Just watch. Take a strong indicator muscle, pull in. Now, take a breath in, hold it in, pull in, okay, let it out. Take a breath in, let it out, hold it out, pull in. So how would I fix that? In the challenge direction on expiration, holding the breath out negated the challenge, or it will also negate the T out. So I'm going to go in the challenge direction. Is it okay? Breathe in and out. 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 Now, just normal breathing. I'm just going to re-challenge it just to see. Pull in. Not good enough. We've got to do a little bit more. Breathe in and out. In and out. That's probably pretty good. Just normal breathing. I'm going to re-challenge. Push in. Push in. That's good. Okay. Turn over. Also, therapy localization should be negative. Bring this one up. Let's take Kenway first. Bring this up. Push up. Push up. And that's good. Let's check the leg length. And it's even Steven. Okay, so that's a respiratory adjustment. Now, I don't use that very often, but I do use it once in a while. And what would be indicated on a respiratory adjustment? A ligament stretch, positive ligament stretch, which we'll cover next time. A positive ligament stretch. Maybe highly osteoporotic. Possibly a hot acute disc, where you may not want to do a high velocity. You may want to do a non-high velocity, like a hot acute low back. Definitely you want to do a respiratory on a cranial. I definitely highly discourage high velocity cranial. Okay, so probably a respiratory on a cranial, ligament stretch, highly osteoporotic, possibly during pregnancy, certain areas, because of what hormone that's released. From the placenta relaxin, which splits collagen fibers. Okay. So those are some instances where you may want to use a respiratory adjustment. I don't use it that often, but I do use it maybe a couple of times a month or something. Okay. It's another tool that you have. Right, Leland?
I didn't get the part about negating the challenge and what that meant as far as where the breath be in or out. Can you explain that part again?
If you challenge a vertebrae and you have a positive right to left challenge, you then have the patient hold the breath in. If holding the breath in negates the challenge, go in the challenge direction on a breath in. If holding the breath out negates the challenge, then you go in the challenge direction on a breath out. So it just tells you whether you need to do it on inspiration or expiration. It doesn't change the direction of the correction. Most of the time we'll see inspiration. This time we saw expiration. 9 out of 10 times it's inspiration. That
Yeah.
Respiratory on high velocity.
would you do a respiratory on a high velocity? Well, you're doing that, usually you adjust on a breath out or a breath in. There are times to adjust on a breath in. Sure. Yeah, that's right, exactly. Yeah, I think I did that yesterday. I think I adjusted the T10 on inspiration. Yeah. Okay. Any questions on respiratory adjusting? You can also do an extremity with a respiratory adjustment. And I don't that often, but you could. It's just another tool. Like maybe if you have an infant, you may want to use a respiratory, but on an infant, they don't cooperate with breathing in and out. Usually you'll do it on inspiration, 9 out of 10 times. So if it's TL through the mom, and you do it on inspiration, it doesn't work, what do? Yeah, just try to do it on expiration. They're a little bitty little thing, and I created a bunch of them. Usually kind of fun to deal with most of the time. Okay, that is the end of the official material for this course. I can't hear you.
Since you were talking about...
I still can't hear you. Stand up.
Since you were talking about infants, you explain like about the no rebound in infants up to a certain age.
That's with cranials, which we start next time.
Okay.
Okay, any other questions? Okay, so here's what I'd like to do on workshop. We're definitely not done. We're here till 1:45, but I may let you out a little early. I'd like you to take about 20 minutes and just workshop that. So just check each other's spines, do a postural analysis. So you get used to doing posture. And then use your tool of therapy localization, identify a few subluxations, and then use your dynamic challenge, or for an anterior thoracic, use a static challenge, and then just fix what you find, and then recheck, okay? So why don't we do that? Let's take about 20 minutes, so we'll start at 10 to 1. Hold the vertebrae interlesion, T2A. Then we covered the extremities. There are no intrinsic muscles, therefore there is no rebound phenomenon. And if we take a weak muscle and then challenge in the direction that we think we need to correct it, if it strengthens the weak muscle, we go in that direction. However, if we start with a strong muscle and challenge into lesion, and it weakens the strong muscle, we then go opposite the challenge in the extremities, because there is no rebound phenomenon. Okay, then we talked about a loved brother relationship, and down to C3 up to L3 they move the same, and then from T4 and L2 up they move opposite. So we also talked about a non-high velocity method of adjusting called a respiratory adjustment, and we simply use the same challenge mechanism. However, we check for a breath in or a breath out. We go in the challenge direction on the phase of respiration that negates the challenge. Okay, we usually adjust it like usually 4 to 5 times. In your case, I think we had to do it 7 or 8. It doesn't matter. You just simply recheck. Your challenge at that point should be negative, and your therapy localization should be negative. Okay? Any questions from the workshop? Okay, good. Any questions from the weekend? Okay, good. Now, do you remember when we were talking about trauma, and I said there are 2 types of trauma, basically? There's the shearing or strain injury, then there's the compaction injury, and we've already learned how to correct the strain that has the trilogy of weak muscle. The synergist has the strain, counter strain, and the antagonist is the fascial flush, okay? You feel pretty good about that? Okay. Now, Would someone say to show you the compaction injury? We have one who needs to be fixed, so. Okay. So the other type of injury is the compaction injury. It's much less common. And that's like the person who gets the rollerblades for their birthday and then puts their arm out and tries to catch themselves, or like, you know, a nosedive off a diving board into a dry pool would kind of be a compaction injury. Or jumping off a ladder would be a compaction injury, that type of thing. And what you'll tend to find, and this is in your handouts, by the way, not your workbook, but this is in your handouts. What you'll tend to find is that all the muscles around the joint that was compacted will test weak, except one. And it's the one strong one that in reality is the weak one. Let me say that again. When you have a compaction injury, for example, let's use the rollerblades. You get there, you know, they got their knee pads and elbow pads and helmet on, and they're going, and then, you know, they all do this eventually, but they put their hand out and boom, they do a compaction injury. All the muscles around the joint, the shoulder joint, will test weak, except for one, let's say subscapularis. But it's the subscapularis in reality that's the one weak one. And to determine if indeed it's due to a compaction injury, you traction the joint opposite the compaction, then retest all your weak muscles. They will temporarily all test strong. That's your verification that you have a compaction injury. Then, this is the part you need to know, the one strong one will weaken after you use patient activation 10 times. So you test the subscap is strong, but you have the patient activated or just contracted 10 times. And after they do that, when you test it, it'll test weak. Repeated muscle activation, patient-induced, RMAP sub I. So on a compaction injury, you'll have all muscles weak, except one. And the one strong one will weaken to repeated muscle activation, patient-induced. You know how to fix it? You do, but you don't know that you do. You fix it with origin insertion. Okay. You'll fix that one joint injury that nobody can fix, and you'll fix it in one visit usually. I'll show you. So, and again, it's written in your handout for you. It's got a flow chart, but you have a history of compaction, not a sprained strain. So like a fall, they try to catch themselves, they jumped off a ladder, a nosedive off a board into a dry pool and do it. This could happen over any joint, a knee, a hip, an ankle, a wrist, a shoulder. Common is shoulder, common is hip. All the muscles will test weak except for one. When you traction the joint, what do you do when you stub your finger or toe? You pull it out the other way. So when you traction opposite the compaction, all those weak muscles will turn on temporarily. That's your confirmation that you have a compaction injury. And then the one strong one will weaken after repeated muscle activation patient-induced, which just is a fancy way of saying you exercise it 10 times. You just move it 10 times. And then test it. And then it'll test weak. How do you fix it? Origin insertion of that one muscle. After you do origin insertion of that one muscle, it won't re-weaken after repeated muscle activation patient-induced. And all the other muscles now will test strong. You're done. Here's the nutrition. Water, wheat germ oil, choline, and in difficult cases, melatonin. That's a polka dot zebra in North America. Okay. Water, wheat germ oil, choline, and in difficult cases, melatonin. John, come on up. Okay, tell us about your compaction injury again.
I fell on the bike, fell on my left side, and compacted the shoulder and kind of twisted me around, and my head hit the ground.
Okay. So he actually has a number of different injuries, doesn't he? It's not a straightforward compaction. For demonstration purposes, you'd like to get a simple compaction, but I promised John I'd fix them today, so might have to. Where does it hurt? Okay, now what's he pointing to there? The insertion of some of the fibers of the serrated anterior. Now I realize we haven't learned that muscle yet, but let's just hold the arm up here, elbow straight, thumb up. This is the upper fibers. They're okay, bring it down. Here's the middle fibers. That's fine, bring it down. That's the lower fibers, TL where it is. Okay, is that a compaction injury? No. No, that's just a simple sprain strain. It's actually more of a sprain strain. Okay? That's the weak muscle that responds to origin insertion. Where would the strain counter strain be?
Synergist.
To the synergist. What other muscle brings the arm up? Deltoid. The strong muscle that weakens after a 3-second maximum contraction push-up. Push, 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 let it totally relax. Bring it back up. Push. There's your strain, counter strain. What muscle is going to be shortened and needs fascial flush? The antagonist, which is probably either the lat or the pec major sternal. Let's check the lat. I was going to hit that, but on your face. Pull in. I'm going to stretch the lat. Pull in. There's your fascial flush. So that's actually what? The first kind of injury. That's your shearing or sprain strain. John, anybody can fix that. And you want me to...
I had worked on before, but it came back.
Hey, if it's worked on before, either wasn't done right or what you need. John, this is very serendipitous because you're the FT rep. You have? Something's wrong. Of course, we're dealing with John, right? Put that on top of the tongue. All right. Push. Can you taste it? Push, that's not doing you any good. So it's not that it's not a good product, it's just that that won't help you. Now, you've had it done. What have you had done? To what? You had fascial. Did you have origin insertion done to the serratus anterior? No. Okay. No. A little bit means not really, no chance plans, no way those days, no buzzer. All right. Oh, we got the fingers ready. It'll be okay. Not a problem. This won't hurt me a bit. Now, remember that the fibers go from the first rib down to the 10th rib. Okay, it was the lower fibers we identified. The upper and middle were okay. So it's part of the lower 4 to 5 ribs. Now, if we wanted to be mean, we could do it in that position, which hurts. But we're not mean, and John's a good guy, and we like John, so we're going to do it in the strain, counter strain position. Not as bad. Yeah, so you find a position of strain, counter strain, that's not nearly as bad as that. Okay? What muscle was the first muscle in 1964? Serratus anterior, John. You're a very lucky guy.
If you want to read it, I'm thinking of it.
No, we're not doing strain counter strain. We're doing origin insertion in the strain counter strain position. Good night last night. Is there a directional component to the serratus anterior for origin insertion? No. Is there a directional component for GTOs? Yes. Is there a directional component for spindle cells? Yes. But is there a directional component for origin insertion? No. You guys are sharp. The next part we do is the elbow. No, next. Getting there. You read these pretty good. Were you going fast, John? 45. Okay, come on up. Okay. Hold this up here, up, down, and down a bit with the lower fibers. That's pretty good. Now re-TL for what? 51%. Do the lower. No, more here. Go where it hurts. That's pretty good. Okay, now, that's it? Okay? So that was not done, I'm sorry. Not like that.
Yeah.
No.
I know that.
Yeah, me too. Okay, have a seat here. Scoot to the right. Now. John, does that hurt?
Yeah.
Put a number on it from 1 to 10.
9.
Okay, now how do we fix the strength, counter strength?
Hold and hold.
Hold and hold, and either on a breath in on the front or breath out on the back. Now it's on the side of the body, the delts and the glute medius are on the side. I'm just going to take a wild guess and try inspiration, okay? So don't you do anything, let me do it. So you find the trigger point, don't you do it, let me do it. Doctor is active and patient is passive. How is it now? Okay, take a breath in. Just relax, John. Don't hold it up there. Just relax. What's normal breath holding time? 40 seconds. If not, check B vitamins and or diaphragm function. Diaphragm is about the thickness of cardboard. It's the major mobilizer of chi in the body. It's like a armature and a dynamo. Okay, now what's the really important part? Slowly I turn. Step by step. Relax. Push down towards the floor again. So why do I have them push the opposite way? So as not to recontract the muscle. Push it. Let it relax. That's a good response. Now, where's the tight muscle going to be? Opposite the weak. That's the other type of trigger point. You have strain counter, fascial flush. That's all there is, folks. So we find it in the left. Okay, that's the other type. That's a strong muscle that weakens after a gentle stretch. That's fascial flush. And what's the nutrition? B12, high thickness. Just iron it out. Please face down. special oil you need for this that only I sell. You gotta buy it from me because I got a patent on it. You know I'm joking, of course. Now, the lat's a big, broad muscle. You gotta do the whole thing. Now, you could also use a little water if you want, if you're doing skin to skin. That's it. It's done. Come up. Huh? Elbow straight. Pull in. Stand up. Move it. Okay. Yeah, there may be other things, but that'll fix that. That'll be done. You may have what? Bruised ribs, and you use arnica tincture. Mother of tincture, arnica, you can use it topical and internal, or 30C potency internal. For hematomas and contusions. Okay. You're welcome. But I wanted to show compaction, didn't I? So is there any? What do you got?
I played in soccer and down my knee, played for both.
You slid in soccer. How did you slide in soccer?
I didn't mean to fall, I was trying to get the ball, but when I went around the girl,
No, describe the fall.
I just fell right down on my knee.
Show me how you did it. Stand up over here and show me, so I don't understand. I just want to make sure that's what we want. Show me over here, I don't care about the group. How did you fall? Did you fall like that, or did you just slide?
Well, I fell at first and I told you it was mud.
Where does it hurt? Okay. Did you fall hard on it, like that?
Yeah, I think it was.
Okay, come on, let's just check it. It may or may not, it might be the sprain strain, or it could be. So she's pointing to the medial knee, she's got a contusion. Okay. Yeah. You can show me. If you want. Okay, lay your back. Now, let's test, now you already know some of the knee muscles, so let's use those. Bring this up here again. Are you on medication? Good. Push up. That's strong. That's strong. Then, wait, hold still. Hold still. Drop it down. Pull up. Does she have it? No, she's already got it. That's a different, that's the other, that's more of a, it's easy to fix. You got a little medial meniscus there, Bill. Somebody have a compaction injury? Okay, whiplash is that a compaction injury? That's a shearing injury. That's a sprain strain. What do you got, Ryan?
Snowboarding.
Tell me.
Snowboarding, just falling backwards.
What did you do?
Just fell back to straight on.
How long ago?
Last winter.
Still not dead? You had it work on?
Not like
Come on up. Oh, bye guys. I'll see you in Vegas next weekend. It's going to be a good one. Birth control is definite medication. It's an allopathic med. Right, a lot of women don't think of it, so when I ask a woman, are you on any current medication, she says no, and I say, does that also include birth control? Oh, no, I'm on birth control, or yeah, no, I'm not on. That would be down here. Which one? Okay, so, do you have any pain? Where? Okay, what's he pointing to? That's supraspinatus. Okay, well, let's just start checking some muscles. I know you don't know a lot of the shoulder muscles now, and that's okay, that doesn't matter, but I want to demonstrate the principle of a compaction injury. Oh, is that okay? Okay. So, are you on any medication or herbs? Hold this over here, elbow straight. Push out. That's the supraspinatus, like, there you go, Michael had. Okay? Now, let's test deltoid, middle. That's weak. Let's test anterior deltoid. Push up. That's weak. Let's test posterior deltoid. That's weak. So far, so good. Let's test teres minor. That's weak. Let's test the lat. That's weak. All right. All right. Hold that in there. We'll test the rhomboids. Sit kitty corner so they can. Okay, let's test the levator. No, keep that in there. Drop the shoulder. Turn your head to the right. That's the levator scap. So we have rhomboids, levator scap, lat. Let's test teres major. Make a fist. Teres. All right. Let's test middle trap. Let's test lower trap. Beautiful. Let's test long head of the biceps. Ha! Ah! Test the triceps. Okay, so far so good. Laying your back. Let's test the two that you guys have learned so far. Pec major clavicular, push up and in. That one's strong. Push back here. Pec major sternal, try the pec major clavicular. This time don't hold your breath. Push. See what he did? What's the breath holding? Cranial. I know he's got cranial. Okay? I can look at Ryan and see. Well, let's test pec minor. Okay, did I miss any? Coracobrachialis, serratus anterior. It's after the teddy. Sit kitty corner so you can. Coracobrachialis. Let's test upper serratus anterior, mid serratus, lower serratus. Isn't the upper trap the shoulder muscle?
Would you retest long head of the bicep for respiration?
So, all the muscles are weak except what? Long head of the bicep. Does that fulfill our criteria? Yes. Now what do we do? How do we confirm the diagnosis? Traction, opposite compaction. How did you fall? Okay, so how am I going to traction? Not too hard though, depending on your strength. Now what do? We test all the weak ones. Good. Do I have to do them all because, or you get the idea? Made it different. Now, in reality, where's the weak one? Right. In his case, the long head of the biceps, the one strong one is in reality the weak one, but it will only show on within muscle activation patient-induced. So there's a long head. Ryan, go 10 times. That's it. There it is. Are you trying? Maybe ready? Get set, go. Okay? Now we know what we got. That's a compaction injury. With me? What's nutrition? Water, wheat germ oil, choline. Why wheat germ oil, choline? because it's using up all the cholinergic fibers. I can't do it. Who said so? Roger Williams said so. And how do you make it? Requires pantothenic acid. Who named pantothenic acid pantothenic acid? Roger Williams. Going to what? Acetyl-CoA, which goes to what? Acetylcholine. It's not my fault. Which requires what? Choline. Wheat germ oil is where you get the acetate groups and B2, riboflavin. That's how you make it. That's why. That is case of unscientific. Now, do 10 times. If you don't believe in AK, means you don't believe in chiropractic, acupuncture, nutrition, homeopathy, craniosacral therapy, SOT, you don't believe in any of that. Or fascial flush or strain counter strain. All George did is take a lot of other stuff and apply it using muscle testing. Push. So let's have him therapy localize the long head. Bingo, let's do the short head. No bingo, let's do the insertion. Do the radial head. All your fingers. Right. No, it's just the one. It's just the long head. That's the only place we have to do origin to. Okay? Yeah. Yeah, don't worry, Brian. I'll be fine. Now, how do I do this for him? Because he's a nice guy and I like him. We do it in the strain, counter-strain position. Now, activate 10 times. Something changed. Took a long time, I realized, out of your busy day. Not that long to know how to do it. Now, let's check the other muscles. How many muscles did I pick? One. How many parts of that muscle did I pick? One. Let's see if we got bingo. Well, that one's good. Middle, lower, make a fist, the one that I forgot before, the subscap, no one caught it. They didn't catch the infraspinatus. Pretty good for one muscle, one position, and one muscle, or one portion rather. Take a breath in, hold it, let it out, hold it out. Your assessment, you're welcome. How does it feel?
It feels different. It feels my thoughts. It felt really loose before.
Yeah, because you had all muscles off except your long head of your biceps.
I stopped playing tennis and everything. I just didn't want to.
You can play now. What if it comes back playing tennis? Dehydration. Okay. Any questions on compaction injury? That was a good example. That was a perfect example for you to see that. That's like 1 out of 10 or 1 out of 20. The other ones are going to be what? sprain strain. Okay?
What point would you check him for nutrition on that?
John, I couldn't hear you.
At what point would you check him for nutrition? Would
If it came back,
the nutrition strengthen up all the muscles or all the other muscles?
I wouldn't do any nutrition unless it came back.
Okay.
Okay? Next, yeah, Al.
When you're done, I have a question on
Any questions on compaction injury? You guys got it? You got the two, you know how much you got this weekend? It's only session 1. Stay tuned. It gets better. That's compaction injury. That was based on the observations of Lee. Okay. Any questions from the weekend?
with the bending, with the, said that,
Are you talking about trunk flexion and extension? That's the plus coming from the work based on thread healing.
right, and
30 degrees flexion or 15 degrees extension. The left upper trap, the left flap, the right SCM, and the right piriformis should turn off.
can you go through this all the four?
That's the PLUF. Left upper, it's all written in your handout. But I just use the left upper trap usually. Because if you just get the one, if you got the one working, then they're all working. So people walk, people bend, you know that part. People chew, and people swallow. That's the part you don't know. That's the T and J and hyoid muscles. People's nervous systems need to function without static. That's the ocular law. Any questions from the weekend? Yeah.
For spring strain, the O's and I's, do they work as well for the back muscles?
Say that again.
For the spring strain with O's and I's and the triad, do they work as well for the back muscles?
Yeah, if you have a shearing injury to any part of the body. Where's the weakness? That's the origin insertion, GTO spindle cell. The strain, counter strain will be the synergist. The antagonist will be the shortened that needs fascial flush. Anyway, whether it's whiplash to the neck, back, elbow, ankle, it doesn't matter. You'll always find that not just on a full moon in June in the Blue Lagoon. You'll see that all the time. Not a rare thing. You can fix usually a sprain strain in one visit. It doesn't mean that they're all healed in one visit, but you need to treat them usually once, maybe twice. Not too much. It doesn't mean that they should go back out to the football game right after you fix them, but they'll heal up much, much faster. I mean, how common is it for a pro football player to be out with a pulled hamstring for 6 to 8 weeks? It's fairly common. You can fix them in one visit. They should be back playing the next week or two. Why do you think the Kansas City Chiefs hired Evan? Why do you think the New England Patriots hired David? But they aren't going to tell what? The other team, because they want the advantage. It's competitive. Not for the hamstring. Like say runners stretch the wrong muscles before they run. They should stretch the rhomboids and not the hamstring.
Craig Beeler, the chiropractor from Jazz, was saying at the sports symposium that Jazz had the lowest injury rate in the previous 18 years of all alleviations.
Okay?
And they've had a chiropractor way longer than anybody else.
Okay, great. Any other questions from the weekend? Okay, how many, okay, I'm not going to ask, but just, if, don't leave, I've got a big finish. If you're not signed up for the whole course, and if you like the weekend, realize this is just the beginning. This is where we start, and it takes off from here. We'd love to have you back. And certainly enjoy every minute, and really want to champion you being here, taking your weekend and attending. I wish we had more doctors like you guys. So if you intend on coming back and have not paid for the entire session, if you could let Dorothy know as soon as possible, would really help us out as far as negotiating rooms and also for ordering workbooks and things. That really helps us out. This is the start. What I would highly recommend is take what you've learned this weekend and use it. Ocular lock, walking gait, piriformis gait, plus the sprain strain injury, the compaction injury, that stuff that you'll use every day for the rest of your life in practice. And I think you got it. You just haven't learned all the different muscle tests yet, but you have to start somewhere. But if you've got that, you've got the big picture. Do it. Do those muscle tests. Not necessarily on every patient, every visit, but do it when they're appropriate. Do a postural analysis and then take out based on your posture. The body is unsparing in its body language. It won't lie to you. And there's a cause for everything. Turn the projector on. So there's a cause, and you can't recognize what you don't know. You don't know what you don't know until you know what you did know, and then you might know. And the more you know, the more successful you become. The more successful you become, the more knowledge you need. The more knowledge you need, the more knowledge you get. The more knowledge you get, the more you know. The more you know, the more successful you become. The more successful you become, the more knowledge you need. The more knowledge you need, the more knowledge you get. The more knowledge you get, the more you know. The more you know, the more successful you become. And did you know that the more successful you become, the more knowledge you need, the more knowledge you need, the more knowledge you get, the more knowledge you get, the more you know, the more successful you become. Just rest on your laurels for a little while and watch your peers pass you by. Now, what can you do to change the world? What happens when we encounter a new thought, an insight, or what we believe to be an idea whose time has come? And what's the funny thing about ideas? We may run to tell our friends all about it, or we may envision how our world will change because of it, or we may just experience what it is and what it does for us. When we arrive at this awakening and see how it transforms us, if it is a true dynamic vision, its power comes when we give it away. How is this done? If the idea is a new one, it may meet with skepticism. If it opposes common doctrine, it may meet with criticism. And if it is powerful enough to transform the world, it may be even vehemently opposed. From the context of, how can I change the thoughts and actions of a world so set in their ways, we can easily slip into overwhelm, and this creates no action. When we share with another one-on-one, we create the opportunity for learning and action. The story is told of a little girl who was vying for her father's attention. The father was engrossed in a championship football game that was on the TV set. The little girl asked her father if he would play question and answer with her, where she would answer her questions like, why is there world hunger? Why do people get sick? Why is there war and fighting? And so on. The father just wanted to watch the TV set on the football. In hopes that his daughter would let him do that, he took a picture of the planet Earth, cut out of a magazine and ripped it into several hundred pieces and told his daughter that this was a puzzle of the world, and when she was done assembling it, he would answer her questions. He figured it would take at least 2 hours if she could even do it at all. 5 minutes later, the little girl returned to her father with the puzzle completely assembled with every piece perfectly placed. Stunned at what she had done, he turned to her and asked, how could you have done this in only 5 minutes? She went on to tell her dad that on the other side of the picture of the earth was a picture of a man. I figured that I could fix up the man and put him back together, and then the world would take care of itself. He gazed at his daughter and began to cry as he was taught a lesson big enough to transform the world. So, what can you do? What can one person do to change the world? Share your experience. Tell them about how one person can change from an unhealthy state to an empowering one. Share the gift of health and well-being. Share your experience with chiropractic, applied kinesiology, and natural health care. and experience how the thoughts and actions of the nation transform into an idea whose time has come. This idea is ultimate health. Hopefully you will see it session 2. Don't forget your hour sheets are be in the front desk to pick those up. You're responsible for keeping track of your ICHA credit hours.
Then I wanted to tell us to work together.